So here's the skin lecture. So the skin has two layers. The first layer is the epidermis, that's the outer layer. The second layer is the dermis. And underneath these layers is the subcutaneous layer, which holds our adipose tissue. So within the epidermis, that has your basal cell layer that forms the new skin cells. The dermis has the elastic tissue, the connective tissue, and the collagen. So what's the function of the skin? So the skin is waterproof, protective, and adaptive. So protection from the environment. So prevents penetration. So prevents penetration and protects from the environment. So this helps with any invasion of any microorganisms or loss of water electrolytes. Also perception. So we have our neurosensory touch. Okay, so pain, temperature, could be pressure. Also temperature regulation. So sweat and adipose tissue. Okay, it helps with the temperature regulation. Along with identification. So identification is a huge skin function because it helps identify, okay, emotions. It helps also with the communication. So if someone's having an irritation or if they're embarrassed, they may be a little blushed. Identification, so I can identify someone from their skin color, okay, and their skin tone. There's wound repair. That's a good function. Absorption and excretion, and the production of vitamin D. So it's necessary for the intestines to have vitamin D to help absorb calcium. So some health history questions is subjective data, things that you can ask your client. So do they have history of skin disease, allergies, hives, psoriasis, or eczema? Do they have a change in pigmentation or color, excessive dryness and moisture, any itching, bruising, rashes? What medications do they take? And if they take a medication, what is it? How much is it? The dosage? When do they take it? How often do they take it? And how do they take it? Have they had a recent hair loss? How much hair? Changes in their nail shape, color, or any brittleness? Do they work in an environment that is a hazard? And what's their self-care behaviors? So what do I mean by self-care behaviors? Do they put sunscreen on when they go outside? Do they bathe? How's their hygiene? These are all good health history questions related to skin. Now for aging adults, I want to ask some more specific questions. What changes have you noticed in the past few years? Do you have a delay in wound healing? Do you have any changes in your feet, such as toenails, bunions? What about their shoe wear? What do they wear? If they're falling, do they have bruises or trauma? And also, what caused them to fall? Do they have a history of diabetes or any peripheral vascular disease? So subject or objective data, we need to prepare. Consciously attend to the skin characteristics. So equipment needed. What type of equipment do you think is needed? So you need good lighting, strong, good lighting. Gloves, especially while you're looking at their skin, is there an open wound? A pen light, because if you don't have good lighting, you need to make sure you have a pen light, and also get a small centimeter ruler, because you need to measure the width, the length, and also possibly the height if it's a raised lesion. Or you also need to measure the depth of that lesion. So inspection, palpation for the skin. So we're looking at the color. So general pigmentation, we're looking at freckles, moles, birthmarks. Now, do I necessarily document every single mole, birthmark, freckles? No, but because what if someone has freckles all over? I'm not going to say they have 10 freckles on the right cheek, 10 freckles on the left cheek. You can generalize it. Are they appropriate for ethnicity, or is there widespread color change? And then note any color change over the entire body of skin. So paler. So this is pale. You could see it in the face, the conjunctiva, the lips, the buccal mucosa. So In a patient who is dark skinned, the most ideal place to look to see the difference of their skin tone, if they're paler, cyanotic, it's going to be the conjunctiva or the mucous membranes. Those are the best spots. So what could cause someone being paler? Could be anemia, could be from shock, lack of blood flow. Now, erythema is known as red. You can see this in the face, on the skin anywhere, pressure sore areas. Now, what could cause some area be red? So erythema. Could be inflammation, infection, maybe a vasodilation, sun exposure, so a sun burn, maybe a rash. Now, cyanosis. This is blue. Again, the best place to know, especially in dark-skinned clients, is our mucous membranes. Conjunctiva or oral mucous membranes or the lips, okay, this whole region. You can check the skin and the nail beds. So it could be due to hypoxia or impaired venous return. Jaundice. So they'll be yellow. Their skin, sclera, mucous membranes. Now, what could cause someone to look jaundiced? It could be because of a liver dysfunction or there's a red blood cell destruction. So note if any changes are transient or due to a pathology, and also note their baseline, and then make sure you know if there's any changes. So if your client comes in pale, but then they start turning cyanotic, make sure you document this because you have to tell their story. You have to paint this picture of what was going on. So this picture, this gentleman is jaundice. This picture this gentleman has, let me take that down. Hopefully you can't see me anymore. This picture, the mucous membrane is very paler. So, temperature, we're going to feel for their temperature. Now, again, when you're practicing with your classmates or at home with your loved ones, make sure that you are practicing correctly. Use the dorsal side of your hand, so the back side of your hand. Why? Because it's thicker. The palmar side is very thick and it can be very moist, okay? Nerves, or some people, it's very rough as well. When you're feeling for their temperature, moisture, or just palpating in general, you're going to want to palpate both sides at the same time. You want to palpate, okay, you're feeling for both sides of the arms, both sides of the leg, because you need to get a generalized idea on what their temperature is. If you have two arms, you got to compare that left to the right, because if that left arm is colder than the right, we have to figure out why. Okay, that's an abnormal finding. I have to look, okay, is there an issue on this arm? So again, use the back side of your hands, the dorsal side. The skin should be warm. Temperature should be bilaterally equal. Warm suggests normal circulation status. Hands and feet might be colder, okay, especially in a cooler environment. Now here's some options to choose from on how you would document your client's temperature. It would be hot, warm, cool, or cold. Moisture. So while you're doing this all simultaneously. So are they diaphoretic or are they very dry? Is it because they're dehydrated? Now texture, again, when you're feeling for temperature, moisture, and texture all at the same time. You don't have to go back up and do it again for each single one. When you feel once, you're keeping this in your head, all these little notes. So texture, is it rough? Is it smooth? Is it bumpy? Mobility and turgor. So decreased turgor or tenting could indicate dehydration or normal aging. So older adults, they can have tenting. So the ideal location is your clavicle area. All you do, and I'm going to show you on my hand again, all you do is you take it, you pinch here, okay, so see how it kind of makes a little tent like, but if I let go, I have good elasticity because I'm younger. But our older adults, if I do this on their hand here, they may stay like this. Once I let go, it may stay up and that looks like a little tent. So it is ideal for everyone to always go up to the clavicle area. So bruising, I want to know more about that bruising. How often do they bruise? And another thing is when I'm looking at the skin, I'm assessing those areas that I'm touching. Okay, so inspection and palpation of the skin, again, with edema. Edema is accumulation of fluid in the tissue. So the skin will appear shiny and tight. It could be because they just got out of surgery and they're edematous, they just got pushed with a crap load of fluids, or they have heart failure and they are fluid overloaded. So you're going to assess all the areas, their arms, their legs, their abdomen. You're going to assess over the bony areas, the shin. So the way you chart it is a 1 through 4 scale. And if you look at the picture, they palpate down. Okay, you push down about 3 to 4 seconds. You release, and then you look, okay, and then you're going to take your hand and gently go over that area you just pushed, because now you can kind of feel if there's an indent. And it goes by 1+ is 2 millimeters. So there's a rapid return. 2+ is 4 millimeters. It takes about 10 to 15 seconds to return. 3+ is 6 millimeters, and 4+ is severe. That's 8 millimeters. So looking at this is about a 4+. You can see the indentation from the fingers, and it has not returned yet. It's a prolonged return. So the complete physical assessment. So the skin assessment is integrated throughout the entire exam. It scrutinizes the outer skin surface first before you concentrate on the underlying structures. So you're going to also look underneath those folds. You're looking underneath those breasts, the obese abdomen, the groin, inspect them thoroughly, because those areas could be moist, warm, and those areas are more prone to infections. Yeah, those pathogens, they love that warm area. And so they get in there and they harbor themselves there. Again, dark, warm, and moist, they provide perfect conditions for the weather, for irritation and infection. Always inspect feet, toenails, between the toes. You want to look at diabetic patients every single day, and you want to educate them every single day. You want to educate them as well that they need to do it every single day. Okay, they must complete this every single day because they have a vascular issue. Okay, so with that vascular issue, they're possibly having diabetic neuropathy also, and that's causing a sensation problem. There's a sensory problem here now. And so when they step on a nail, they may not feel it. Or they're in between their toes is very moist, okay? And now there's possibly an infection brewing. There was redness, but they didn't see it. So let's talk about lesions. So if there are any present, you want to note the following. You want to note the color. Is there multiple colors? What color is it? Elevation. What's the height of it? Or is there any? Is it flat or raised? The pattern or the shape, is it oval? Is it jagged? The size of it, is it 6 millimeters, 6 centimeters? How big is it? The location, and is it distributed throughout the entire body? So such as a rash. Is there any exudate? So note the color and the odor. So again, exudate is drainage. Now, do I need to go, what does it smell like? No, but if there is an odor, and a lot of times if there is a foul odor, you're going to be able to smell it when you get a little bit closer to actually do a good examination. A Woods light just helps just kind of detect the fluorescing lesions. So usually as nurses, we don't use this, but we will assist the providers with this. A focus exam. So individuals will seek health care for any skin problems, such as like if they go to a dermatologist or their PCP. You're going to assess the skin as one, and then you're just trying to get that overall impression. And then when you find that lesion, you're going to inspect them very carefully. Now, with a rash, you're going to check all the areas of the body. You cannot rely on the history. So to say that the rash is just in that one spot, just like that gentleman I talked about, he had a rash on his trunk, but when we asked him to lift up his pant legs, he had the hives on his lower legs as well. And then we realized he was covered, completely covered in them. So it wasn't just one area, it was all over. So skills used are, again, inspection first, then palpation. So melanomas, we did this in lab, but we're going to do an ABCDE assessment. So A is for asymmetric. Is one half of that little melanoma unlike the other? So they're circles. So is one like this, and then this side is huge, okay? Are they equal? B, the border is irregular, scalloped, or it has a poorly defined border. C is color. It could be varied, could be having different shades. Sometimes it's white, red, or blue. You have to note the color, because if it changes, then you can see where it's changing from and to. D is diameter. So usually they're greater than 6 millimeters, so the size of the pencil eraser, but also they can be smaller. E is evolving. So such as in the mole or lesion, and I'm going to ask the patient, so they come in and they're like, well, I have this bump here, and it just really it's irritating now. And so what I'm going to ask is, when did it start? Has it changed color? Has it changed the border? The diameter has gone larger? And that's going to help me understand, has it been evolving? So here's an example of asymmetric. So it's one half of it is not like the other. B, the border is very scalloped. It's very jagged, has a very poorly defined border. This color here, there's multiple color. They just vary throughout the whole thing. The diameter is larger than 6 millimeters and it is evolving. So this is where it started. So it started here and then it just kept going. So that's evolving. So here's just a little example of benign versus malignant melanomas. I'm going to let you take a look at this, but this is just to give you an idea on what they look like. So I'd like you to just look at this, and we'll do this again in class. But I'd like you to take a look, and this is a patient. He's 50 years old. He's a construction worker. He lives in Arizona. His name is John Johnson. The patient noticed this new lesion on his right cheek and scheduled an appointment with his primary care provider. You, the nurse, are performing an admission history on Mr. Johnson. You know he has a past medical history of hyperlipidemia, so high lipid levels in the blood. Now you are going to be collecting data on this possible melanoma. So now you need to document it. So how would you document it? Using the A, B, C, D, E. So now we're going to talk about hair and nails, but hair first. So when we look at someone's hair, one, you are going to look at the color. It's going to be due to the melanin production, but as a patient gets older, as a human gets older, they may have less melanin, which is causing their hair to turn gray. I'm looking at their texture. Is it straight, fine, curly, thick? All of this could be affected by hair products. Distribution, I want to make sure it's even. Is it consistent? Or do they have patches? Lack of hair on the legs can be a sign of vascular disease. Now, if they have any lesions, okay, we need to identify that by looking at the scalp and identifying the hair, or dividing the hair into sections. Now I'm going to look at the nails. I'm looking at the shape and the contour. So from a profile side, okay, view the index finger at its profile, and it should be 160 degrees. So as you go, kind of where the matrix is, you can't see that, but it's underneath, you are going to have a little dip, and then your nail is going to go up. That's about 160 degrees. Consistency. Is it consistent? Do I have all my nails? Okay, color. Are they pink? Do they have white spots? Capillary refill. So you're going to press down on your nail bed here. Okay, release. It went from white to pink in less than 3 seconds. That is ideal. It is a good status of peripheral circulation when it goes less than 3 seconds. So color return is normally instant. Sluggish return can take longer than those 3 seconds. Here are some of the books, I know ATI and then F.A. Davis, they may say a little bit different, but 3 seconds is pretty key. So for this one, okay, so looking at the shape and the contour, I can't see a profile of these nails, but I can see how these nails are curved downward. They look like they have a degree higher than 180 degrees. So this could actually be clubbing. So clubbing is caused by patients who have a oxygen issue, possibly COPD, heart patients can have this. So we'll go more into this in just a little bit. So here's a question. We're going to do this together. The nurse is assessing a patient who is postoperative day 0. So POD 0, following a total hip replacement. The estimated blood loss during surgery was 400 milliliters plus. What finding would the nurse expect? So we know that this client is postoperative because it's saying that he's postoperative from a hip replacement, and he lost blood during surgery, about 400 plus milliliters. Do you expect him to be erythema, cyanosis, paler, or edema? I'm going to expect him to be paler because of the anemia, the blood loss. So it's a common finding. Okay, I'm going to let you guys do this one, and this one, and this one. Now, skin presentations when a patient is aging, they're going to have uneven pigmentation. They possibly might have senile lentigens, which is the liver spots in that lower, those hands that are shown. They could also have that dry, flaky skin. It's very thin, it's translucent, they tear easily, there's the loss of elasticity, and there's wrinkling. They have a decreased hair growth if their hair starts thinning. Their nails start to decrease as well for the growth, and it starts thickening. The surface may be very brittle. They have slow wound healing. So when they get those skin tears, it may take months for it to finally heal. They have little subcutaneous tissue over the bony prominences that will help protect them. And they have a decreased skin turgor like we've talked about. So again, older adults, they have a loss of elasticity. The skin folds and sags. Decreased skin turgor could just be due to age. And the best spot for that is the clavicle. Sweat and subcutaneous glands is decreased number and function, leaving the skin very dry. So it's very important that these clients, they don't excessively wash because that's going to dry out their skin. Plus, with just aging, it's going to dry out their skin as well. The senile purpura, so it's discoloration due to increasing capillary fragility. Their breakdown due to multiple factors. The cell replacement is slower. Again, wound healing is delayed. Their hair matrix, okay, so this is leading to gray fine hair. So this is a skin tear, so that loss of elasticity, and they may have just bumped into the wall, and then they have this skin tear. And now it's causing this wound healing delayed because of their age as well. Again, so a loss of elasticity, so the wrinkles. And then this is the senile purpura. So you see how there's just like little discoloration due to the increasing capillary fragility. So cultures and genetics. So assessment on dark-skinned patients, again, so always check their oral mucous membranes. It should be pink. But to see if there's any discoloration, this is the location you need to look. There's an increased likelihood of skin cancer in whites rather than in blacks and Hispanic population due to the melanin in the skin. So this client has what type of lips? Like, how would you document that color? Cyanotic, absolutely. So again, we're going to go over lesions. So we're going to inspect and document what we find. The color, the elevation, the height, is it flat or raised, the size, the shape, location, and is there any drainage, so exudation. So there's vascular lesions that you may see. Petechiae, I've seen this very often. It could be due to infection or trauma. So when you look at someone's arm or leg or body that's petechia, it looks like little fluid dots. Okay. Then there's ecchymosis, so this could be from trauma. So this looks like a very large bruise. It's just a collection of blood in the dermis area. It's greater than 3 millimeters in the diameter. Then there's purpura. This could be due to an infection or bleeding disorder as well. So here's the petechia, here's the ecchymosis, and then purpura. Now, with this ecchymosis here, with any of them, you really want to get the size, and you want to also ask, is there pain? Because if this starts growing, you may have a huge problem here because it's a vascular issue. Now let's talk about primary lesions. So we have flat lesions. So an macule, also known as freckles. There's a patch, which could be from a birthmark or any hormone changes. Raised lesions, so there's a papule, which is a wart, mole, or skin tag. A plaque, such as eczema, could be on the hands. There's a wheal. Let me take this off. This bottom one they look like wheals, okay? So, but this is an allergic reaction. So these are hives. Raised solid, so a nodule, which is also known as a melanoma. A vesicle, okay, that's shingles, could be varicella, could be also eczema. A tumor, so nasoplasm. A raised fluid filled, okay, lesion. You have a pustule, such as herpes simplex or acne. You have a massive cyst here, okay? Now, me personally, I love draining them. I think they're kind of an exciting moment. But because I don't know why, I love when the doctor goes in there and they just get it out. The sign of relief for the patient, it's kind of crazy to look at them because they're in so much pain anyways, but then getting all that pressure out, it really does help. Now, is this within my scope of practice? Absolutely not. A bulla is a blister, so this could be from a burn. It could be from the sun exposure as well. Secondary lesions, so they evolve from their original status, but change their characteristics. So go back into Health Assess, Module 4, titled Skin, and take a look at all of the lesions that are on there. So clients may develop pressure ulcers, and these could be on the bony prominences. So areas that are thin, they're bony, so such as my elbow, my shoulder, my scapula, my greater trochanter, my occipital, my coccyx, my heels. It could be my ankles, could be in between my knees, could be on the side of my knees, could be multiple locations. Wherever it's bony and I'm putting pressure on it for a long period of time. So who's at risk? Elderly. Their loss of elasticity and less subcutaneous fat, excessive moisture, if there's any shearing or friction, especially when they're getting lifted up in the bed. And let's go back to excessive moisture. It could be because of elimination or because they're sweating. Or also it could be due to maybe they had their bath, but they weren't fully dried. Immobility, not being able to be mobile and move that circulation around. That could cause a pressure ulcer. Obesity, extra weight in that area is causing more pressure when they're standing down and they're immobile as well. Poor nutrition and hydration. Vascular disease. If they have any sensory deficits. If they are edematous. And also if they have any chronic diseases. So what should you do? I'm going to make sure when I change their linens that they're wrinkle-free. I don't want to see any linens in there because you may cause that client a pressure ulcer. Reposition your client every 2 hours or even more. If they're sitting in the chair, you want them there for less than an hour, but every 15 minutes, they need to shift their weight. They need to move their cheeks side to side. Make sure the head of the bed is lower than 30 degrees because when it's higher than 30 degrees, okay, this is about 30 maybe. It's a weird angle when you're looking at it. But then if you're like this, right here where we meet, this is where the buttocks is. And it's causing so much pressure right here. Float the heels. So if they're laying there, make sure their heels are floated. Make sure those heels are off that pillowcase. Ambulate them. Do range of motion. Now the range of motion can be done every 2 hours as well, or every hour when you do your hourly rounding. And remember, when you do your hourly rounding, you're asking them, pain, do you need to be repositioned? Do you need to go to the bathroom? Pain, position, potty, the 3 Ps. If they're immobile, please use a lift device. Don't try and lift them from their shoulders. Use something to help lift them up, because you lifting them from their shoulders or grabbing their legs, you're going to cause possibly shearing or friction and cause a tear, and or cause some damage to that skin. Use a specialty mattress. Assess them using the Braden scale, and we're going to talk about this in class, but I highly recommend you looking at this prior to class. Clean the skin with warm water and little friction. Apply moisture barrier cream. The barrier cream is essentially just like diaper cream, but very thick. And make sure they have good nutrition. So high dense foods, high protein, 2 to 3 liters a day, and a lab value. Okay, you want their albumin, which is a protein, greater than 3.5 grams. So again, when we're looking at these wounds, okay, like let's go back to my grandma. If I was looking at her wound, I'm going to start assessing it. I'm looking at that wound bed, the color of the wound bed. So here's the wound. The wound bed is the inside. Is it red? That's a healthy regeneration. Or is it yellow? The presence of purulent drainage or slough. Is it black? The presence of eschar or necrotic tissue. This requires removal for healing. We must remove that eschar or necrotic tissue, but there's certain ways to do it. We can't just like scoop it out. In lab next week, I'm going to bring in some examples of wound care for pressure ulcers and how to take care of them, just so you can get an idea. So also, other than the color, I'm going to look at the size. I'm looking at the length, the width, the depth. Is it undermining or tunneling? Okay. I'm using the clock for locations. I'm looking at the exudate, which is drainage. How's the odor, the amount, consistency? Is the color serous, serous sanguineous, or purulent? I'm also looking at the surrounding skin. Is the surrounding skin edematous? Is it red or fumatosis? Is it macerated or is it intact? I want that skin intact. So let's look at this wound. How does this wound look? That wound bed, is it red? Okay, it looks really moist. The drainage appears yellow. This looks like it's on a heel or an ankle. Okay. What else do you think? So this is the exudate. Let me close this real quick. We're going to go over this in class. So you have your serous sanguineous, and then your purulent. So staging pressure ulcers. So there's stage 1. We have to have stage 1. Okay, so stage 1 is a non-blanchable erythema. The skin is intact. There's a darker skin tone. In darker skin tones, it may appear blue or like a purple hue. So right here, darker skin tone. So what's happening is that what do I mean by blanchable versus non-blanchable? So just similar to the cap refill, when you push down, it goes white and then it comes back. That's blanchable. Okay, that's like an idea of what blanchable means. But when it's non-blanchable, okay, you're pushing down on that ankle. Okay, let's go to that ankle in the right upper corner. But yet it never goes white. It stays red the entire time. It's non-blanchable. Stage 2 is partial thickness loss. So the skin breakdown of the epidermis and the dermis. This is superficial. There's a red-pink wound bed. So right here, this is the buttocks. So the wound bed is nice red and pink. The outer part, you can see the edges. And then you can also see right here, okay, the actual skin that's surrounding it. It's red and inflamed. Stage 3 is a full thickness loss. This is damage to the subcutaneous tissue. This is deep, but without exposure of the muscle or the bone. So again, this looks very moist right here on the outer part. The wound bed is nice and red, but you have to be very careful on this part here because not only can this spread, like not spread, but it can get worse. You have to make sure the outer area is nice and dry. Okay, stage 4, full thickness tissue loss, tissue necrosis or damage to the muscle, the bone, or any underlying tissue. So right here, if you look, okay, that's possibly a tendon or a bone. There's going to be slough or eschar or tunneling. So in here, we go this way. Okay, let's see if I can change this color. If we go this way, there's tunneling right in there. Now I want to go back to the tunneling part real quick that I forgot to mention. Now I want to know how deep that is. So I'm going to take like a Q-tip, a long Q-tip, and I'm going to insert it, and I'm going to measure how long it is in there. I'm going to describe that in class so you can all see. All right, so the next one is unstageable. So these ulcers are covered with eschar and slough. I don't know how deep it is. I don't even see the wound bed. I can't even stage this. Now I can stage this, but I cannot stage this. So this eschar and slough, it should be removed, but you're not going to remove it by yourself. You're going to make sure you have orders on how specifically on what to do for this. And a lot of times for pressure ulcers, there's going to be a wound care nurse. There's going to be a physician on board always, so then you can get those orders. So then there is a deep tissue injury, a DTI. This is discoloration, but the skin is intact. There's damage to the underlying tissue. So, excuse me, it's localized. So this is the heel. So it appears as a bruise, but with intact skin. So this is just to show you like an animation of what each part looks like. So lesion patterns and configuration. So there's annular and circular. So what could this be? What do you think? Something that's an annular or circular. This is ringworm. So here is a good example of what ringworm looks like. How about confluent? What does it look like? Doesn't it kind of look like hives? A little bit, right? It also could be rubella. So this is an example of rubella, kind of spread throughout. Linear. So linear, you can think of as a line. Okay. What do you think this could be? This is herpes zoster. So herpes zoster is shingles, and it's along the nerve root. So just like this. Oh, is that painful? Absolutely. It can be very irritating and very painful. Okay, so then there's grouped lesions. So what could this be? This is contact dermatitis. Now, when we were talking about infection control with latex allergies, some people get contact dermatitis and it's just on their hands and it could be grouped. So here's this, just an example. So here's a question. So the lesions in the illustration are best described as grouped, annular, polycyclic, or linear. What do you think? It's linear. So this is actually herpes zoster, so shingles, because it's along the nerve root. Okay. So bruising. There's multiple stages for bruising. But another thing is if there's different bruises at different stages of healing, and there's excessive bruises above the knees or elbows, it should raise some concern for physical abuse. Now, we know that children, they fall, especially younger toddlers, they fall, so they get a lot of bumps and bruises on their lower shins. Okay, but if there's things that are on the core, the trunk, the arms, I'm going to be worried about it. Now, what if you saw this? Would you report this? What do you think? What if you saw this? Would you report this? Yes, you are required to report this. Absolutely. So we're going to talk more about that in class on the reporting. But let's talk about the stages of bruising. So stage 1, okay, so pink, red, okay, so that's day 1, all right? So until like maybe day 5, it starts turning purple and they're that dark purple and that blue. Day 7, it'll start having that like pale green color. And then until it completely heals and goes away, it's going to have that yellow-brown color. So here's another example. So stage 1, you have that pink color, then it turns purple, then it goes yellow, a little brown here.